I've been given a lot of ammunition yesterday and today, and I am going to take the liberty to maybe go over a minute or two here. So please excuse me. In the United States, the national pastime is a sport called baseball. And in the 60s and 70s, there was a catcher for the New York Yankees named Yogi Berra. And he was also sort of a comedian. And he said, "I hate to make predictions, especially about the future." And that's what you're asking me to do, and I will go ahead. I think the future of spine surgery resides in 4 arenas: technological advances, resource utilization, allocation, operative indications, and the advancement in spine care delivery. Regarding technological advancements, we have total disc arthroplasties, dynamic fixation, artificial facet joints, biologic imaging advances, MIS, robotics, and on and on. We can just see the explosion of all of this happening, and it has been stated that this is the future of spine surgery, but I question that. Is the tail wagging the dog here? How many advances can society reasonably absorb as costs climb and efficacy potentially declines? We talk about cost effectiveness, and an individual procedure may be cost effective, but if it's widely used, is it affordable by a society? I take a step sideways here. This is a highly stenotic spinal canal, a CT scan. Can you see my pointer?
Yep.
Okay. With the stabilizing part of the facet joint being medial, and if you take off too much of that, the prevention of translation cannot happen. So folks have developed minimally invasive strategies to deal with decompressions. And here we see a minimally invasive approach where the contralateral approach side was decompressed effectively, but in order to effectively decompress the ipsilateral side, excessive facet joint needed to be, or it didn't need to be, but was removed. And so I asked the question, and we must really separate true minimally invasive surgery from minimal incision surgery. That last operation I showed was a minimal incision and maximally invasive operation. We also have to question operating on patients that may be treated more effectively otherwise, and maybe the most minimally invasive operation is either a weight reduction operation or no operation at all. And dealing with complications, as we see here, can be horrendous problems. Also, the surgeon here may have lost an opportunity to cause this patient to change their lifestyle and lose weight, hoping that the surgery would fix their problem and not deal with probably the major aspect or causative agent in the patient's problem, which is the weight. So most research that's published these days is conclusion-based research, research that is designed to prove a point and not process-based research. The first is frequentist-based on frequentist probability, and the later is exploratory inquiry based on Bayesian probability. Fundamentally, with conclusion-based research, the literature is flawed, and there is a mounting amount of studies that demonstrate that early findings are not sustained. Here we see most published research findings are false, and the truth wears off. And the now famous Scott's parabola demonstrates early participation and the utilization of a technology, then the truth wears off and we end up without not using it. The trouble is, the area under this curve may represent a significant expenditure of money and injury to patients. So there's all sorts of bias that go into the research. Surgeon evidence-based bias, patient-based bias, selection bias, study design bias. But with conclusion-based research, the studies are usually bias-laden, with the bias all in one direction. And with exploratory inquiry, there may be bias, but they're neutral. The different biases going in different directions, neutralizing each other. So the second part is research, utilization, and allocation. We know that in the United States, certain spine operations have a 10-fold difference in per capita utilization from region to region, and regions sitting right next to each other in our country. We most certainly see resource maldistribution in the world as we face problems worldwide. Operative indications. How do we really assess our patients? Are we studying patients with health-related quality of life metrics? And can AI, artificial intelligence, or machine learning help us sort out who to operate on? Unfortunately, many patients that we operate on have, instead of a surgically treatable problem, have a chronic pain syndrome. Chronic pain for more than 3 months, non-restorative sleep, low energy level, inactivity, 24/7 pain, and on long-term opiates. The phenomenon or the clinical entity that we can operate on is mechanical back pain, deep and agonizing pain worsened by loading, improved by unloading. But oftentimes there is a pseudo-concordance, an apparent but erroneous relationship between an assumed cause, i.e. an imaging study, and an effect, back pain. If a patient has a chronic pain syndrome, but also has an L4-5 spondylolisthesis, and keep in mind, L4-5 spondy is an imaging finding. It is not really a diagnosis. The clinical diagnosis would be chronic pain syndrome or mechanical back pain, for example. And if the patient gets an operation who has a chronic pain syndrome, that is shame on the physician. So you can ask questions. Have you had pain? Have you had low energy level? Do you sleep okay? Do you spend most of your day laying around? Do you suffer? Do you have pain in more than one part of your body? In other words, multiple unrelated somatic complaints. If many of these answers are true, you may be wanting to think about not operating on a patient with degenerative strategies. So we ask patients, well, we do have foundational strategies to deal with them. Active treatments, weight loss, as in that lady I showed earlier, exercise, cessation of smoking, etc. And then there's passive treatments like pills and laying there and saying, doctor, treat me. So core strengthening, flexibility, smoking, cessation of weight loss, these are all lifestyle changes. Unfortunately, at least in resource unchallenged areas of the world, people are standing in this line that are overweight smokers, unwilling to do lifestyle changes, but more than happy to receive pills and surgery. So can artificial intelligence and machine learning and big data help us? Maybe. We know that with 1 and 2 level decompressions, that there is 40 to 80% of the patients at our institution miss the MCID on functional and quality of life outcomes, and on average only 60% of them reach their MCID, which means that we're not as good as we think we are, and we need to rethink how we think about selecting spine surgery. And then advances in spine care delivery. We need to start with people from all over the world, not just North America or Europe. Here is an article from Dr. Jha in a resource-challenged area of the world who couldn't afford operative instruments. So he goes to a shop and makes micro-dissecting instruments. This is ingenuity. This is innovation. So all the technologies that we talked about most of the technologies that we have talked about address first world problems, degenerative diseases of the spine. But what about what happens in middle and low income countries? I think we're getting there a little bit. Education, distribution of resources, communication through venues such as we are experiencing here today, the World Spinal Column Society, World Neurosurgery, World Federation of Neurological Surgeons, etc. I thought, and I think Paulo must have shared my comments with Dr. Munting, but he gave a great talk yesterday, I thought, on affordable spine care worldwide. Is it a dream? Can we leverage technology to address middle income and low income resource inequities? We just heard Michael Wang say yes. It's going to take time though. I think he mentioned maybe not in his lifetime. So this morning I got an email and I got from Dr. Munting, and I asked if I could share it with you all. He says, I thank you for your nice comments following my recorded presentation to World Spine. I felt a bit old-fashioned without praising robots and many fancy and fantastics techniques available nowadays. But I'm convinced that the right indication, in particular for surgery, remain the most important point in our endeavors, still too often neglected. I hope the message will get across to our younger colleagues. Hope to meet you sometime in the future when King COVID-19 allows us to travel. I think we need to seriously heed and contemplate his words. So yes, we can do education and distribute resources and communicate. Our world is indeed getting smaller and smaller. And I believe that that is the true future of neurosurgery. Instead of focusing on what we do as a commodity or a job, we should focus on what we do as a labor of love and a calling. We should focus on what we do not as how much we do, but but the good we do, volume-based versus value-based care. And industry, a la Michael Wang, must participate. We cannot ever hope to perform a $500,000 operation in the vast majority of the world. And a screw is a screw. We need to work on getting industry to participate. COVID-19 isn't all bad. It has enhanced the utilization of technologies like Zoom, et cetera, for communication and education. And this in turn can't help but facilitate the redistribution of resources, in particular human resources and education, but hopefully down the road, technology and supplies. The better we know each other, the more effective we communicate and the more effective we can be at distributing all of these resources. And so I'd like to leave you with a comment by Machiavelli. There is nothing more difficult to plan, more doubtful of success, nor more dangerous to manage than the creation of a new order of things. Thank you very much.